Good day, everyone. This is a continuation of our discussion under secondary hemostasis. Now, for this lecture, we will focus more on the different hemorrhagic disorders manifesting in the presence of any coagulation factor deficiency or abnormality, as well as the various laboratory procedures and tests used to assess these deficiencies. You might already be familiar with the various causes of bleeding in an individual. These causes may be a result of an injury experienced by the patient. However, in this lecture, the causes of bleeding that are not necessarily due to a direct injury or trauma inflicted upon the patient shall be the main focus. Here you will understand the different classifications of bleeding or hemorrhage, or the excessive bleeding that requires medical or physical intervention. So now let's go to the different symptoms of bleeding depending on their classification or cause. Bleeding or hemorrhage can either be localized or generalized. A localized hemorrhage is one that occurs at a single location. This may occur in the presence of any form of injury, infection, tumor, or even an isolated blood vessel defect. Surgical sites that are not cauterized or sutured well can cause localized bleeding to occur. This is different from bleeding caused by reduced platelet counts or vascular system defects because these types of disorders or bleeds are generalized in nature. As a result, spontaneous and or recurring bleeding may occur in multiple sites, often requiring medical intervention. General bleeding occurs when there are issues in the primary or secondary hemostasis, as well as in uncontrolled fibrinolysis. Oftentimes, a generalized bleed or hemorrhage may either be seen mucocutaneously or anatomically. A mucocutaneous bleed is one that is typically seen in the patient's skin or at body orifices. This type of bleed is observed when the patient has issues with the primary hemostasis. Take note, the primary hemostasis. The typical examples of mucocutaneous bleed are gum bleeding, nosebleed or epistaxis, hematemesis, hematuria or blood in the urine, melena or blood in stool, and menorrhagia. All these seen in conditions involving the primary hemostasis defects. Meanwhile, anatomic hemorrhage occurs in soft tissue, muscles, joints, and even deep tissues due to defects in the secondary hemostasis. This is notably observed when a patient undergoes minor trauma, surgical procedures, and even during dental extraction. Again, for mucocutaneous hemorrhage, this is seen when there are problems in any component of the primary hemostasis, whereas anatomic hemorrhage is observed when the components of the secondary hemostasis are affected. Laboratory testing is always warranted when generalized mucocutaneous or anatomic bleed is detected. This slide shows the various tests done to narrow down or identify the cause of the patient's bleed. Complete blood count, or CBC, is a routine test in hematology. This test is used to check for thrombocytopenia. Aside from CBC, coagulation tests like prothrombin time, activated partial thromboplastin time, thrombin time, and fibrinogen assay are also tested. The importance of each test shall be discussed shortly. Lastly, whole blood clotting assays using thromboelastography and thromboelastometry may also be performed to measure the whole blood clotting process. And lastly, bleeding may also be due to acquired and congenital disorders. However, the characteristics of bleeding due to acquired or congenital disorders vary. For acquired bleeding disorders, these may be due to vitamin K or C deficiency, liver disease, and even kidney failure. As such, these acquired disorders show bleeding tendencies after childhood, with bleeding tendencies or symptoms not present among the patient's relatives. Meanwhile, congenital bleeding disorders are seen early in infancy, and bleeding symptoms are seen in first-degree relatives. Examples of acquired bleeding disorders include von Willebrand disease or VWD, hemophilia, and acquired qualitative platelet disorders, which will also be discussed shortly. Now that we have already classified the different bleeding symptoms, it is now time to move on to the different acquired bleeding disorders or coagulopathies. As what was discussed in the previous slide, symptoms of acquired bleeding disorders are seen after childhood and are not seen among relatives. Acquired coagulopathies may result from trauma, drug exposure, liver and kidney disorders, and nutritional deficiency, among others. To start, coagulopathy is a term characterized by a single or multiple coagulation factor deficiency. There could be several causes of coagulopathy, and knowing each cause is important to properly address the signs and symptoms that the patient might have. The first on the list is trauma-induced coagulopathy or TIC. This is a condition wherein coagulopathy results from any form of trauma that could trigger systemic shock. These triggers include a combination of injury-related acute inflammation, hypothermia, acidosis, and poor distribution of blood to tissues associated with low blood pressure or hypoperfusion. Again, all these TIC triggers may possibly lead to systemic shock. Two possible consequences could occur whenever there is systemic shock. First, systemic shock leads to the reduction of ADAMS13, which is a von Willebrand factor cleaving protease. When ADAMS13 is reduced, von Willebrand factor will not be cleaved, and there will be a rise in von Willebrand factor multimers, leading to von Willebrand factor triggered platelet activation. Another possible consequence of systemic shock is the excessive tissue factor release, which leads to the activation of coagulation, the loss of control proteins, and hyperfibrinolysis. The strategies employed to manage a patient with trauma-induced coagulopathy greatly depends on the severity of the patient's condition and on what the patient really needs. Massive transfusion is prescribed when the patient has lost a lot of blood volume. Now, by definition, massive hemorrhage is defined as blood loss exceeding the total blood volume within 24 hours, the loss of 50% of blood volume within a 3-hour period, or blood loss exceeding 150 ml per minute. In such cases, massive transfusion is given to correct the patient's hematological profile. Next is plasma transfusion. Plasma transfusion is done for multiple coagulation factor deficiency since fresh plasma contains all coagulation factors. However, when the plasma is stored at refrigerator temperature or thawed after freezing, factor V and factor VIII activities decline as they are sensitive to cold temperatures. Next is platelet concentrate. Platelet concentrate transfusion is done to correct thrombocytopenia, but is ineffective when the patient has immune thrombocytopenia, thrombotic thrombocytopenic purpura, or heparin-induced thrombocytopenia. Other factor concentrates may also be administered to the patient depending on what the coagulation factor the patient lacks. Concentrates are administered to reduce the risk of transfusion-associated circulatory overload or TACO and transfusion-associated lung injury or TRALI. The second cause of acquired coagulopathy is liver disease. The liver has several important roles such as synthesis, conjugation, detoxification, among others. It is important to note that most coagulation factors and regulatory proteins are products of the synthetic function of the liver. When there is liver disease, the biosynthetic function of the hepatocytes are adversely affected. This is seen in hepatitis, cirrhosis, obstructive jaundice, carcinoma, poisoning, and disorders of bilirubin metabolism. In liver disease, there is an alteration in the production of vitamin K-dependent factors. As a review, your vitamin K-dependent factors are factors 2, 7, 9, and 10. Aside from the vitamin K-dependent factors, The production of control proteins such as protein C, S, and Z is also affected. These coagulation factors cannot participate in the coagulation process because they are produced in their des-gamma carboxyl forms. Additionally, among the 7 factors whose production is altered, factor 7 is the first to exhibit a decreased activity since it has the shortest plasma half-life. This is the reason why prothrombin time, a test which is sensitive to factor 7 activity or deficiency, is prolonged in mild liver disease. Fibrinogen is an acute phase reactant. Acute phase reactants are markers of inflammation that change their serum concentration in the presence of inflammatory processes. Although there is an increase in fibrinogen production during mild liver disease, the fibrinogen produced is coated with excessive sialic acid, making it unable to function normally. In end-stage liver disease, fibrinogen levels may decrease significantly. Lastly, for von Willebrand factor and factors 8 and 13, which are also acute phase reactants, they may be unaffected or elevated in mild to moderate liver disease or damage. Liver disease does not only alter the production of coagulation factors, but it also affects the number of circulating platelets. Moderate thrombocytopenia occurs in 1/3 of patients with liver disease due to sequestration and shortened platelet survival due to portal hypertension. In alcoholism-related hepatic cirrhosis, on the other hand, platelet production is suppressed. Disseminated intravascular coagulation, or DIC, is also a possible consequence of liver disease. DIC, as defined by the National Institutes of Health, is a condition characterized by a widespread hypercoagulable state that can lead to both microvascular and macrovascular clotting and compromised blood flow. DIC, secondary to liver disease, is due to a decrease in the production of regulatory proteins such as antithrombin, protein C, or protein S. Moreover, activated procoagulants are also released from degenerating liver cells, which cause coagulation to occur rapidly. Aside from this, the diseased liver also cannot clear activated coagulation factors, thus contributing to the clinical progression of DIC. This slide shows the different laboratory tests that are monitored in patients with liver disorders. As discussed earlier, fibrinogen is an acute phase reactant and it becomes elevated in early and mild liver disease, but eventually decreases in concentration in patients with chronic liver disorders. Thrombin time is a screening coagulation test designed to assess fibrin formation from fibrinogen in plasma. Thrombin time is prolonged in the presence of dysfibrinogenemia, hypofibrinogenemia, and in the presence of elevated fibrin degradation products. Take note that thrombin time is affected by heparin therapy. Additionally, reptilase time is also prolonged in dysfibrinogenemia, but it is unaffected by heparin therapy. Prothrombin time screens for extrinsic and common pathway coagulation factor deficiencies. In liver disease, it is useful especially in screening for vitamin K dependent factors whose production is altered, such as factor 2, 7, and 10. Activated partial thromboplastin time, or APTT, is also prolonged due to altered factor 2, 9, and 10, which are also vitamin K dependent factors. Factor 5 is decreased in liver disease but is more liver specific since it is unaffected by vitamin K deficiency. The next classification of hemorrhagic disorders are due to congenital coagulopathies. Otherwise known as inherited coagulopathies, congenital coagulopathies have a genetic predisposition and involve a deficiency of coagulation factors. The first example of a congenital or inherited coagulopathy is von Willebrand disease. This disorder got its name from the Finnish professor Erik von Willebrand, who first described the disorder. Von Willebrand disease, or VWD, is the most prevalent inherited mucocutaneous bleeding disorder caused by qualitative or quantitative abnormalities of von Willebrand factor. Epistaxis, ecchymosis, menorrhagia, hematemesis, gastrointestinal, and surgical bleeding may be seen in patients with this disorder. And since von Willebrand factor is also a known carrier of factor VIII, von Willebrand disease can also lead to factor VIII deficiency. Von Willebrand factor is coded for by the VWF gene located on the short arm of chromosome 12. It is a multimeric protein that undergoes post-translational glycosylation to become a glycoprotein with a size ranging from 500,000 to 2 million Daltons, making it the largest molecule in human plasma. This molecule is synthesized by the endoplasmic reticulum of endothelial cells or by megakaryocytes. VWF, synthesized by the endoplasmic reticulum of endothelial cells, are stored in Weibel-Palade bodies in the cytoplasm of endothelial cells, whereas those synthesized by megakaryocytes are stored in the alpha granules of platelets. Seen on this slide is how VWF is produced and stored. Von Willebrand factor is stored in Weibel-Palade bodies of endothelial cells and in platelet alpha granules. When the need for VWF arises, Weibel-Palade bodies and the alpha granules fuse with their respective membranes to release von Willebrand factor into the bloodstream. Before release, von Willebrand factor is coiled, but once they are released into the bloodstream, shear forces of the blood flow uncoils the multimeric molecule where they will be cleaved by the enzyme ADAMS13 into shorter multimers. Several monomers make up the von Willebrand factor multimer. Each monomer contains 12 subunits within the 4 domains, so that's domain A to D, that support the active sites at the locations indicated on the diagram. For example, domain A supports a receptor site for collagen, ADAMS13, and glycoprotein 1B. Domain C provides a site for the binding of glycoprotein 2B3A complex, and domain D provides a receptor site for factor VIII. This slide shows the various types and subtypes of von Willebrand disease. Type 1 is quantitative in nature, caused by frameshift, nonsense mutations, or gene deletions, leading to low von Willebrand factor and factor VIII. Type 2 von Willebrand disease is qualitative in nature and has 4 subtypes. Lastly, type 3 von Willebrand disease is caused by translation or deletion mutations, which can lead to severe mucocutaneous and anatomic bleeding tendencies due to low or absent factor VIII. Another inherited coagulation disorder is hemophilia A, also known as factor VIII deficiency or classic hemophilia, or Royal's disease. Interestingly, hemophilia A was actually the disorder of Queen Victoria's son. This is an X-linked recessive disorder. Certain mutations on the X chromosomes cause quantitative or qualitative factor VIII disorders, leading to hemophilia A. Just like other types of hemophilia, factor VIII deficiency exhibits anatomic bleeds, hematomas, acute or chronic hemarthrosis, which can bring discomfort to the patient as this causes movement to be limited, musculoskeletal lesions and deformities, neurologic deformities due to intracranial hemorrhage, and transfusion-transmittable infections such as chronic hepatitis and human immunodeficiency virus infection due to repeated exposure to blood products. In classical hemophilia, or factor VIII deficiency, diagnosis is done by first checking the history of the patient, especially on incidences of hemorrhagic symptoms. Since this disorder only involves the deficiency of factor VIII, the patient will have normal results for prothrombin time, thrombin time, and fibrinogen assays. However, activated partial thromboplastin time will be prolonged because, as discussed previously, APTT is a coagulation test that screens for factor deficiencies in the intrinsic and common pathways. Factor VIII is an important factor belonging to the intrinsic pathway, thus, we have an expected prolonged APTT result in hemophilia A. The next inherited disorder is hemophilia B or factor IX deficiency, sometimes called Christmas disease, named after a person with the surname Christmas. Similar to hemophilia A, hemophilia B is an X-linked recessive disorder. A deficiency in factor IX reduces thrombin production and causes soft tissue anatomic bleeding. To diagnose hemophilia B, family history is of utmost importance. Incidences of hemorrhagic symptoms must be well noted. And since factor IX still belongs to the intrinsic pathway of coagulation, the only coagulation test prolonged here is APTT. Prothrombin time, fibrinogen, and thrombin time remain normal. Now, to confirm for factor IX deficiency, immunoassays may be employed to measure or quantify factor IX. Then we have hemophilia C or Rosenthal syndrome. This is a disorder due to a decrease in the production of factor XI. It is an autosomal dominant hemophilia with mild to moderate bleeding symptoms. Interestingly, factor XI deficiency is a disorder common among Ashkenazi Jews. Since factor XI still belongs under the intrinsic coagulation cascade, this factor deficiency may be suspected in a prolonged activated partial thromboplastin time or APTT. PT will be normal together with the other tests not specific for deficiencies of the intrinsic coagulation pathway. These are the other single factor deficiencies which presents mild to severe bleeding depending on the severity of the disorder. For factor XIII deficiency, moderate to severe systemic bleeding and poor wound healing is observed because of a deficiency in the factor that stabilizes the fibrin clot produced during coagulation. So that's it for the hemorrhagic disorders, which can be classified as either acquired or congenital or inherited. You may refer to our main reference for more detailed discussion on these topics. Thank you for watching this video.